La Escuela de Medicina y Ciencias de la Salud se fundó en Monterrey en el año de 1978, y es ahí donde está el Centro de Innovación y Transferencia en Salud, el Hospital San José y el Hospital Zambrano Elion. En Ciudad de México se encuentra la Unidad de Investigación de Enfermedades Metabólicas del Instituto Nacional de Ciencias Médicas y Nutrición, Salvador Subirán. En la ciudad de Guadalajara, el Centro de Ciencias de la Vida. En Chihuahua, la escuela es parte de Tec Salud, integrándose también el Hospital San José, Hospital Zambrano Elion, institutos y Fundación Tec Salud, formando un centro de atención, educación e investigación. Ser la mejor escuela de medicina y ciencias de la salud de Latinoamérica es nuestra visión, enfocándonos en bienestar, prevención y longevidad. Nuestros programas académicos: médico cirujano odontólogo, licenciatura en nutrición y bienestar integral, licenciatura en psicología clínica y de la salud y licenciatura en biociencias. 17 especialidades y subespecialidades médicas, 30 cursos de alta especialidad, una maestría y 2 doctorados. Nos caracteriza nuestro modelo educativo innovador, creando una experiencia transformadora con alianzas educativas en todo el mundo, 8 grupos de investigación con enfoque estratégico y más de 50 alianzas educativas en todo el mundo. Sociedades académicas para monitorear y apoyar a los alumnos, posicionándonos dentro de los primeros 5 lugares en el examen nacional para aspirantes a residencias médicas. Nuestros programas cuentan con acreditaciones nacionales que respaldan su formación, siendo la primera escuela privada que tiene convenio con la Secretaría de Salud del Estado de Nuevo León, a través del programa multicéntrico. Y somos la única universidad privada en México que figura en el ranking QS de Medicina en Latinoamérica. Ahora que nos conoces, explora, elige, libera tu potencial transformador.
Muy buenos días, tengan todos ustedes. Soy el doctor Oscar Valencia, coordinador de este espacio de Educación Médica Continua. Y antes de dar inicio a nuestra sesión, les recordamos mantener en silencio sus micrófonos. Todas las preguntas las podrán hacer a través del chat y al final de la presentación las haremos llegar a nuestra ponente. También les recordamos que nos hagan favor de llenar una encuesta de satisfacción. Esto es muy importante para nosotros y también para la sesión, para ustedes. Y también una cosa importantísima es que tengan el nombre completo en la pantalla, esto con fines de tener el nombre que debe aparecer en sus constancias. En nombre de la Escuela de Medicina y Ciencias de la Salud del Tecnológico de Monterrey, les doy la más cordial bienvenida a esta sesión académica de pediatría. Hoy tenemos un tema muy importante, anorexia nervosa atípica, y con una invitada muy especial, y le voy a permitir a la doctora Eva Trujillo que nos haga favor de presentar a nuestra ponente y conducir esta sesión. Adelante, Eva.
Muchas gracias, Oscar. Buenos días, gracias a todos. Pues es para mí un gran placer presentarles una amiga de muchos años. Ella es la doctora Jennifer Gaudiani. Ella es fundadora y directora médica de la clínica Gaudiani y está certificada por el Consejo de Medicina Interna de los Estados Unidos. Ella hizo su licenciatura en Harvard, hizo la Escuela de Medicina en la Universidad de Boston y su residencia en Medicina Interna y fue jefe de residentes en la Universidad de Yale. La doctora Gaudiani se ha desempeñado como director médico en el Centro Acute para Trastornos de la Alimentación antes de fundar la clínica Gaudiani, que es una clínica médica ambulatoria con sede en Denver, que se dedica al tratamiento de personas con trastornos de la conducta alimentaria y con disfunción alimentaria. Y trabaja bajo el paradigma de la filosofía HAES, que es Health at Every Size, o salud en todas las tallas, que esto abarca el tratamiento de personas de todas las figuras corporales, tamaños, edades y géneros. Además, su clínica es de las pocas clínicas en los Estados Unidos que tiene licencia para ejercer en más de 35 estados de los Estados Unidos y lo hacen a través de telemedicina, además de que da muchas consultorías y educación internacional, nacional e internacional. Ella ha dado conferencias a nivel nacional e internacional, publica ampliamente en la literatura científica, en revistas de alta indexación, en blog, es miembro de la Academy for Eating Disorders, somos colegas y miembros del consejo editorial del International Journal for Eating Disorders, que es el journal premier del campo de los trastornos de la conducta alimentaria, y ella es miembro del Comité de Normas de Atención Médica de la Academy for Eating Disorders. Tiene un libro que se llama Sick Enough, A Guide to Medical Complications of Eating Disorders, que se publicó hace 4 años, creo. Está en Amazon, es un libro excelente que para cualquier persona que le interese adentrarse en el campo de los trastornos de la conducta alimentaria desde la perspectiva médica, básicamente, es el libro por donde empezar. Entonces, Jenny, sin más preámbulos, I'm so honored, so happy to have you here. Thank you for accepting and for waiting up so early. And this is our medical community, and welcome to Monterrey, and please start.
Muchas gracias, Eva. Muchas gracias, doctor Valencia. Qué placer estar aquí. Bueno, desgraciadamente no puedo dar mi lectura en español porque me faltan el vocabulario y también la gramática, pero me encanta hablar español, me encanta practicar cuando puedo y tal vez un día puedo hacer una lectura completamente en español. Bueno, aquí estamos. Okay. Can you see that okay, Eva?
Yes, Jenny.
Wonderful. All right. Welcome, everybody. I'm so excited to share this topic with you. Here are my objectives. I hope by the end of this talk that you will be able to diagnose and educate patients, caregivers, and other clinicians about atypical anorexia nervosa, understand the medical and psychological sequelae of atypical anorexia nervosa, and hear how diet culture and thin privilege operate as systems of oppression that harm all of us, and in particular those with atypical anorexia. Specifically, I'll establish the foundation, the big picture physiology of starvation. We'll remember how many individuals are invisible in eating disorder treatment. I'll review the literature, prevalence, diagnosis, physiology of atypical anorexia. We'll consider some social justice themes that influence. We'll go over a few cases, including a mystery diagnosis case. And I will propose weight-inclusive care or health at every size as the best way forward. I love to begin lectures with this quotation. We must encourage practitioners to locate the problem of fat shame in society as opposed to the individual person's body, and provide individuals with tools to identify and resist fat stigma and oppression, rather than provide them with tools to reshape their bodies. So what is atypical anorexia nervosa? It is anorexia nervosa, restriction of food intake, fear of fat or gaining weight, but without the underweight. And it's very interesting because anorexia nervosa, which gets the most attention, has a population prevalence of 0.1%, whereas atypical anorexia nervosa has a population prevalence of 3%. So which one is atypical, actually? It's important to remember that atypical anorexia carries a double death rate compared with healthy peers. It is not a stage, it's not acting out. It is a serious psychological and medical condition with a very high death rate. And why do we even say anorexia versus atypical? Well, from my perspective, it is about the weight stigma, even in the Diagnostic and Statistical Manual 5, which gives us all of our psychiatric diagnoses. For instance, we don't say atypical binge eating disorder versus typical binge eating disorder based on a weight cutoff. And we don't have a cutoff for other mental illnesses that cause medical complications like atypical self-harm or atypical substance use disorder based on some arbitrary cutoff. All right, let's talk about the big picture. I always review this with my patients and their families. I like to talk about the biology of deprivation because it helps us bring science to what is otherwise an internalized belief in many of us, the worst probably in medicine, that weight is very individually determined based on good choices. And in fact, there's a lot of biology we have to be aware of. Our brains evolved to protect us from death by starvation. As our ancestors were evolving, they did so in a time of want, not plenty. And the only reason we're all here today is that their brains evolved to resist and protect us from starvation. And this topic doesn't mean starvation skinny people. This means anyone who is experiencing malnutrition, regardless of body shape or size. And so what happens in what I call the cave person brain, meaning our ancient brain that we have no control over, is that it says, oh, I'll protect you. If it's been 3 days or a week or 3 weeks or 3 months that we haven't been nourishing ourselves properly, and it changes our physiology across the board in order to slow our metabolism and protect our body weight. And there's different and same ways that people present. I will discuss all of the ways that our brain changes our body, but each person's presentation will be unique to themselves. If you take the same height and age person and you give them the same caloric deprivation, one person may have certain symptoms and another person may have others. And that's because of our genetic makeup, what I call sensitive genetics or survivor genetics. We might be more familiar with this when we think about alcohol use disorder. Probably we've all taken care of a 35-year-old man who dies of liver cirrhosis after 5 or 10 years of heavy drinking. And also we've taken care of the 90-year-old man who says that he's old and healthy because he's been drinking his whole life. And the difference between those two guys is their genetic sensitivity. So some patients are very sensitive to starvation. As soon as they begin restricting, they feel terrible, their digestion shuts down, they feel weak and exhausted. And those patients often feel shame because they say, why can't I do this better? I'm not even thin yet, and yet I feel so bad. Then we have another population of patients who may have been starving for decades, but they're working a job, they continue to exercise, they have very few medical complications, even if they're very underweight. And those patients feel shame because they say, why isn't my body falling apart? I guess I'm not doing my eating disorder well enough. So we can see it's a no-win situation when it comes to eating disorders. So how does our cave person brain manage to change our body? Well, it says, I will slow your metabolism to save your life. And it does this by giving us cooler body temperatures, including hands and feet, acrocyanosis. It slows the heart rate. It slows digestion. It reverts sex hormones to pre-puberty, which then contributes to fragile bones. And then a starved mammal is not creative and playful. It's serious, rigid, rule-bound. It's a little paranoid because it knows that it's not safe and it views the world with suspicion. And this very much describes the brain of individuals who are malnourished, regardless of body size. Plus, our brain is very smart. It's been evolving for a long time. When a human hasn't gotten food enough for a while, our drive for food, our obsession with food increases. And our body seeks to preserve our weight. You know, interestingly, they did metabolic studies on hunter-gatherer tribes in Africa. And they found to their surprise that even though these folks are walking 10 or 15 miles a day, they burn no more calories than I do sitting at my desk seeing patients, because the brain manages the metabolism to protect our weight. In addition, once we've lost weight or we've been starving, the brain says, oh, okay, I'll take care of you. When we have access to food again, let's make sure we gain all the weight back, plus some, to make sure that next time you enter a starvation time, you'll have some extra resources to use. And this is why dieting does not work. It works for the first week or two, maybe 3. Everybody feels so great. And then biology kicks in. This is not a matter of individual failure. It is a matter of biology that is baked into our brains to allow us to survive. Importantly, even with very significant restrictive behaviors, some people's weight never goes down. In fact, sometimes it rises. And it's easy for a scientist to think, how is that possible? You can't possibly gain weight on too few calories. But the way we were all taught about metabolism, calories in, calories out, is nonsense, unfortunately. I mean, it has its basis, but metabolism is very responsive to caloric intake. So some people just gain weight when they reduce calories. Here's the danger. Health cannot be determined by appearance. But this is what we as doctors do all the time. We have 10 minutes to see a patient. We walk into the room, we take a quick look, we make certain assumptions. And the reason we do is that the big diet industry, which in 2019 was a $200 billion industry, the big food industry, and the industrial healthcare complex make us wrongly equate the appearance of certain bodies with positive or negative health outcomes. So here are some truths. Caloric restriction is a nearly universal element of all eating disorders. Dietary restraint has become the new defining behavior of virtuosity in society. It's not the deeds you do that make you a good moral person anymore. It's what food group you're avoiding this week. And that serious medical considerations result from restriction. But as long as there's such a thing as looking healthy, medical providers will wrong patients. I have patients in my clinic who get stopped on the street by strangers who say, "You look so beautiful. You must be so fit. Wow, what do you do?" And they're in 3 organ failure and suicidally depressed. We have to stop linking appearance with health. It's a big challenge. Figuring out body symptoms of people with eating disorders is very complicated for a variety of reasons. One, the system is not intersectional. Everyone is doing their work in a different space, and we don't communicate and we don't put the whole human together. Usually, the medical profession does not honor the mind-body connection. We have a paradigm of care where only what is measured is real. So even though we can't measure a migraine headache, we know it's real. But when these patients who are psychologically complicated and medically ill come in and say, "My tummy hurts," and the CAT scan is normal and the blood is normal, and they keep suffering, it's very common that they hear from the doctor, "It's all in your head. It's just your anxiety." But there are a lot of medical problems that can't be measured. When eating disorders continue to be thin focused and in a society that conflates thinness with health. So many people are missed and harmed in our field, partly because of oppressions and partly due to our own limitations. I've found great peace in my 40s in this field, understanding the ways I've caused harm and thinking with curiosity and openness about how I might do better. So the core problem is that historically, research, clinical, and medical care have focused almost exclusively on female, white, young, cisgender, able, visibly underweight patients. When the reality is that eating disorders affect a very diverse patient population who are made invisible by present-day stigma and practices. Let's talk about a few groups. These action figures, I'm a big Star Wars nerd, these action figures on the left are the ones that were released in the 1970s with the original Star Wars, and they're Han and Luke. The two on the right were re-released in the 2000s. And you can see that although the characters nor the actors changed, their body types are grossly different. In fact, the ones on the right could only possibly be attained through steroid use and an eating disorder. So does this matter? Am I too serious about this? Well, let's think about the costumes that we're putting our little boys in. When you put a little boy in a costume like this that has pecs and delts and abdominal muscles showing, we are telling our little boys that the only way they can be magical or superheroes is if they have the body that looks the part. That's a big problem. We know that discrimination drives eating disorders. In an important study, the higher the discrimination experienced, especially along body size or skin color, the greater the prevalence of binge eating. There was a 1,000% increase compared with those who did not experience discrimination. What about trans individuals? In a large study, those who were assigned female at birth and identify as gender non-binary had the highest rate of self-reported and diagnosed eating disorders in their lifetime at 7.5%. Non-binary individuals were 3 times likelier to have had an eating disorder compared with trans binary individuals. In another large study, transgender college students were 2 to 4 times, 200 to 400% more likely to use eating disorder behaviors than a reference population of cisgender heterosexual females. And what is this? Probably minority stress, which is the excess stress experienced by individuals in stigmatized social categories along gender, racial, religious, sexual, and other lines. These individuals experience a wide variety of deep exclusion, stress, and harm that others don't experience. In fact, in an important study, patients with gender or sexual minority had double the incidence of historical sexual abuse, bullying, and trauma. Of 2,800 patients assessed at an eating disorder center, were 17% identified as sexual and gender minorities. So eating and body concerns affect everyone, and stigma harms everyone. Traditional medicine thinks about action-reaction, when really it's much messier than this. And I love sitting in the messiness. Okay, let's talk about anorexia nervosa. The measurement of weight suppression is really important. And as pediatricians, this will be key. Remember, not all restriction leads to weight loss, but rapid or significant weight loss, regardless of body size, can cause serious medical complications. And so we measure this as the highest recent body weight minus the current body weight divided by the current body weight. Even a 5% weight suppression may cause serious medical complications. And you think, how can that be? Because we're constantly telling patients to lose 5% of their body weight. This is a really important conundrum we've got to be thinking about. There's also a lot of diagnostic overlap. 57% of participants with purging disorder and 52% with bulimia nervosa also met atypical anorexia nervosis criteria if we consider 5% weight loss. What about those who don't lose weight? So just when we think like, okay, great, I'll pay attention to weight suppression, not body size, there are those who don't lose weight. They are just as ill psychologically and medically as my patients who do lose weight, because even if their body weight doesn't change, they are still starving mammals. Okay, so what's the incidence here? Well, in treatment programs, we saw in the US, 8% of those admitted were diagnosed with atypical anorexia in 2005, 47% just 4 years later. Anorexia nervosa was 59.5% and atypical was 40.5%. In a BMI percentile group, lower BMI, median BMI, and high BMI were very widely distributed in anorexia nervosa in children and adolescents. All right, let's look at the literature review. All the medical complications seen in anorexia are seen with equal frequency and severity in atypical anorexia, except maybe bone density loss and hypoglycemia. In adolescents with restrictive eating disorders, total weight loss and recent weight loss are better predictors than admission weight of medical complications. Compared with anorexia, adolescents with atypical anorexia were in larger bodies before their eating disorder, had lost more weight over a longer period of time, had no significant difference in the frequency of medical complications or psychiatric severity, as you see in this list, no significant group differences regarding the occurrence of binge eating, vomiting, laxative misuse, or compulsive exercise, and distress related to eating and body image was more severe in atypical anorexia. We can understand why. These are patients whose families, coaches, and friends may have been celebrating their weight loss even as they were getting sick. And so the idea that they now have to eat and likely restore body weight is very distressing, because they also see the patients who got thin, who get more tenderness and respect, and it's a terrible double standard. In a study of adolescents, average 16 years old, 91% female, the eating disorder examination questionnaire global score was higher in atypical anorexia. And independent of admission weight, a lower heart rate was associated with faster weight loss, and a lower serum phosphorus was associated with a greater amount and longer duration of weight loss. We also know that metacognitions and drive for thinness is the same in anorexia versus atypical. I hope I'm giving you the point that it is an accident of biology who happens to end up underweight versus not, but it's the same diagnosis. Now, hypoglycemia. Data aren't available, but I have long seen and lectured that hypoglycemia causes death in anorexia because it causes the heart to stop. Carbohydrate intake being inadequate, glycogen stores being depleted, and patients with anorexia nervosa have little muscle or fat stores left. So they can't keep building glucose in the absence of adequate intake, and the heart stops. But I suspect that because those with atypical anorexia happen to have preserved weight, probably they have a lower risk of hypoglycemia that's severe, and maybe this explains the death rate of 2 times age-matched peers in atypical versus 6 times in anorexia. What about bone density? So I expect the reading systems are the same in the US and Mexico. My apologies if they're not, but we'll just go through the adolescent column and then we'll briefly touch on the young person column. We know that Z scores are used, that above -2, they're officially normal, that below -2, it's bone density lower than expected for age. And with osteoporosis, you have to have a bunch of long bone fractures. For young people under 50, remember, it's still Z score and it's still bone density lower than expected for age at less than -2. But if you have a -2 And any secondary cause, as we'll discuss a source for, or a fragility fracture, that's osteoporosis in somebody under 50. However, for young athletes, the International Olympic Committee says a Z-score of less than -1, not -2, is low. So when I have a young athlete, 18, 19, whose Z-score is less than -1 in the spine, plus they don't have a period due to inadequate fueling because they have hypothalamic hypogonadism, that's osteoporosis. Interestingly, adolescents with atypical anorexia had better bone density scores than adolescents with anorexia. And in one study, a Z-score of less than -1 was present in 80% with anorexia and in 69% with atypical anorexia. And the lack of a prior low weight and the lack of prior amenorrhea was protective against bone loss, but a history of overweight or obesity, not terms that I use, was not. In conclusion, maybe it's the higher body weights before and during anorexia that sustain the period, which keeps estrogen levels up more and thus better bone density tests. But remember, bone density loss is the one medical complication of starvation that may never fully resolve. So don't chance it. Okay, so we now know that they're pretty indistinguishable in terms of psychological and medical pathology. Are these two patient groups treated any differently? Yes. In terms of duration of illness before admission to treatment, it was 20 months in the 37% of patients who previously had overweight or obesity, and only 11 months in patients who had a normal weight before. So despite a greater degree of weight loss and no difference in duration of illness, participants with a history of higher weight are less likely to receive inpatient medical care. All right, let's go through some cases. Santiago is an 11-year-old boy. He's always been at the 80th percentile weight, 50th percentile height, which is what his family body type is. In the last year, he's been hungry all the time. His weight rose, and he expressed self-consciousness about his body, especially his belly. His mom expresses concern to the pediatrician at his well visit, and the pediatrician says he's now 90th percentile weight and very kindly says, hey, we got to be a little more careful with food here, watch the sweets. Oops, talks openly with Santiago and his mom about the future medical risks related to high weight. So Santiago is like, okay. He cuts out sugar for Lent and he starts to lose weight. People praise him. That feels good. His list of off-limits foods grows rapidly, and he starts counting calories and exercising every day. After 4 months, his weight is lower than it was at his 9-year-old well visit, even though he's still not formally underweight. His grandparents and uncles are telling him he's looking great. He's now at the 40th percentile on the growth chart when his mom brings him back to the pediatrician, quite worried that he won't break any of his food rules. The pediatrician very wisely diagnoses atypical anorexia nervosa and refers him to a great dietitian who works with him on beginning to fuel better. Then suddenly overnight, Santiago starts binging on all the sweets in the house and his weight rises rapidly. He feels out of control and ashamed and tells his mom he must have been right. He was addicted to sugar. He can't have any. All right, so let's think about restricting to binging. This is biological. It's not universal, but it is biological. This is not a problem of willpower. It can be very scary and shame-inducing for patients, and it's an important reminder of why consistent, non-scarcity eating is best. I take care of a psychiatrist in the US who's finishing his residency, and his parents all his life told him, you've got to diet, you're too fat, you've got to diet, only eat low sugar, only eat low fat. And that scarcity mindset, I'm not allowed to have things, were what drove binge eating disorder. So I just saw him last week. We've been working together quite some time. He now knows he can eat whatever he wants in moderation. Anything is allowed. And he says, Dr. G, I haven't had a binge in months. I can keep food in the house that used to be completely unsafe. And he said, it's all about getting rid of this scarcity mindset. So Santiago is at risk for diagnosis switching to binge eating disorder. And I'd like you to remember that rebellion and restriction are the key drivers of binging. Okay, sugar addiction, there's no such thing. Biology, we cannot be flat earthers on this situation. So what I like to tell patients is that when your ancestors and mine were walking through the rocky desert and we didn't get enough food for a couple of days, and we get to the edge of a forest where we find a honey hive, a beehive, our ancestors did not go, well, okay, let's keep walking. We took it down and we ate all the honey because that's how we survived. So when people are deprived of something, they will binge on it. It is biology. And the world is obsessed right now with low carb eating, but everyone needs carbs. 50% of our energy should come from carbs. Now, what about Santiago's puberty and his weight? Multiple studies show that dieting among adolescents leads to greater weight gain. The less you eat, the slower your metabolism, the more likely your natural set point weight rises. It's biology. It's not a moral failing. And body dissatisfaction is the #1 predictor of early onset eating disorders. So child, parent, doctor worry about a surge in pubertal weight must be very delicately managed. Discussion should center around moderation, expectations, and body compassion and patience. So let's go back and replay what would have been better for Santiago at his original appointment. Let's say the pediatrician instead asks open-ended questions about how Santiago is feeling about his hunger, his body, his relationship with food and movement, and what conversations he's hearing about weight, because kids get so much talk about this. Remember that doctors carry great power either to reinforce weight stigma or to apply a scientific lens and heal it. The pediatrician shows him his growth curve, and she says, look, adolescence is a time for major gains in height and weight, and gaining in the tummy is super normal. If she learns that he's been using food to self-soothe or for other reasons than satisfying hunger, or maybe there's food insecurity present in the family, or there's a divorce happening, let's refer the patient for support and reassure them that eating enough throughout the day is what's best for his body. Never dieting, never denying himself some of what he wants. This psychoeducation for Santiago and his mom, that this is a risky time for disordered eating to start, and that his weight and body will be healthiest with no lifetime dieting, and to pay more attention to habits than to body shape and size. Okay, our second case is about weight restoration goals. Valentina is a 10-year-old girl who began puberty early. She's always been 60th percentile for weight on the growth curve. Her pediatrician sees her weight has risen quite a lot over the past year and warns her and her mother to make significant changes. There's a strong family history of diabetes, so Valentina and her mom are worried. Just like Santiago, within 6 months, Valentina has lost a lot of weight and fears food and weight gain, even though she's not formally underweight. She's tired, can't concentrate, can't sleep, has constipation, feels cold all the time, and is very anxious with OCD behaviors, and she's stopped growing taller. The pediatrician recognizes all these symptoms are from atypical anorexia nervosa and refers the patient to an excellent therapist and dietitian. But now everyone wonders, what should her target weight be? Does she have to return to the 95th percentile she was before she started losing weight? Or the 60th percentile she was before she hit puberty? Target weight is a challenging topic because of weight stigma. For the most part, kids should get back to their most usual percentile on the growth curve. This is a screenshot from a fabulous video. Write it in your phone. Please check it out. Eva Musby growth chart. It's an 8-minute video that is the best for practitioners, patients, and their parents. What we don't want to do is under-restore weight, or the medical and psychological issues may persist or become chronic. We have to identify our own tendency for internalized thin bias. So these months of recovery are really hard on Valentina's parents. They have to oversee every meal or she won't eat enough. They can't believe she needs more than 3,000 calories a day to gain 1 or 2 pounds a week. For a child who's afraid of eating, this is torture. But hypermetabolism is almost universal when people need to restore weight. However, almost like magic, when she gets to the 70th percentile of weight, her patients say, my girl is back. She's happy, creative, more relaxed, and her body distortions really improve. The last case is about resuming athletics. Camila is a 17-year-old with atypical anorexia who's been getting good treatment and has been doing better. I couldn't use the American term. She's been a football player since young, and it's a big part of her identity. But overexercise has also played a big role in her eating disorder. She'd like to get back to football in her recovery, and her team wonders, when is this safe? My experience is that with clear exceptions around psychiatric instability or medical instability, movement makes recovery sustainable. Saying, don't move, you'll burn calories, only reinforces the eating disorder belief that that's all exercise is for. So as soon as Camila proves she can fuel herself consistently as recommended by her dietitian, she's gaining weight or her weight is stable, and her vital signs have improved, we have a number of options. One team member, dietitian, therapist, doctor, might take the lead on guiding movement parameters and really making sure there's consensus. We might start 1 or 2 days a week of mindful, sport-appropriate movement that builds strength and endurance. If she wants to run, you might say 5-minute walk, 5-minute run, followed by processing it in a journal, and then talking with her therapist. Did you stay present? Did you dissociate? We want to keep the movement varied, strength, cardio, stretch. We want to keep following her medically with accountability to make sure she's still getting what she needs and resting is appropriate. This is not exercising every day. Advance these as able, or if the coach is really good, you can have the coach oversee this and communicate with the team. But let's talk to Camila about the fact that finding her athletic identity again, the fun of resuming her sport and living her values, are the rewards of recovery, and they can very helpfully replace the eating disorder identity. Okay, are you ready for a mystery illness? This has become one of my favorite things to treat. Every time I lecture on this, I get an email back at least once, often more, from either a listener who says, I have that, or my mom has that, my sister has that, or from people who are like, I have 3 patients with this. I never knew what it was. So I'm very excited. And we're going to try to answer, what if many symptoms could be caused by one diagnosis and properly treating it could prevent an eating disorder? Okay. Isabella is a 13-year-old who presents with fleeting rashes and abdominal pain. She's been getting burning stomach aches and a drippy nose after meals, no matter what she eats. When she gets embarrassed or angry, she develops a lacy transient rash up her neck, chest, and face, and it feels hot. Once she had an allergic reaction to an unknown trigger, which required an emergency department visit as her throat started to get tight. She gets intense flushing of her nose at times, itchy skin when she runs around with friends, swollen hands and feet when she's out in the heat for a few hours. In fact, when she sits out in the sun, she's exhausted like no one of her friends. Strong scents and even use of hand sanitizer can cause her to have headache, flushing, and nausea. So she started to restrict food and lose weight just because she feels so uncomfortable after eating. Are you ready? This is mast cell activation syndrome, or MCAS. It is a pleomorphic syndrome, so many different presentations, so many different severities, in which histamine is released when it should not be, which results in patients having symptoms that range from very mild to life-threatening. Mast cell activation syndrome is also a major driver of postural orthostatic tachycardia syndrome, or POTS, usually hyperadrenergic subtype. And these POTS patients will not get better until their mast cell is diagnosed and treated. This is an amazing article. It doesn't matter whether pregnancy is involved. The review of mast cell in this article by the world expert, Dr. Afrin, it's so helpful. And the next image comes from this article, and it shows all the different organ systems that can be affected by mast cell activation syndrome. So it's no surprise. I didn't ever hear of mast cell activation syndrome until about 4 years, when patients, my referral base is unusual, who had problems with eating and undiagnosed medical complications began coming to me from around the country. And I was like, what is this? And I learned, and now I see a lot of this. We don't know enough about the prevalence, but it's thought that maybe up to 17% of the population has some sort of histamine problem. And it's only in the last 5 or 10 years that we've been paying attention to it. In my very specialized population, I take care of about 30 or 40 patients out of 130 who have mast cell. How about diagnosis? There's 2 schools of thought. Consensus 1 is only those who have measurable blood and urine abnormalities can be diagnosed. That's very Western medicine. I'm very Western medicine trained. But consensus 2 is where I sit, which is anyone with a reasonable number of symptoms can be started on mast cell treatment. And if they feel better, they have a mast cell issue. Why are we getting too fussy about it? So here's treatment. Step 1 is always figure out and avoid triggers. There is no such thing as a truly low histamine diet. But when patients are really active in their mast cell, every food they eat may trigger a reaction. So we don't want to prescribe restrictive eating, but the dietitian does have to listen to the patient's lived experience and allow maybe for certain foods to be off the list until the mast cell is more controlled. Interestingly, you have to reduce heat and sun exposure. Not that this matters for children, but alcohol is toxic for patients with mast cell. I have patients with mast cell who feel suicidal for 3 days after they drink alcohol, in addition to their itchy skin. But alcohol is in hand sanitizer and sometimes in inhalers. So we've got to watch that. Sometimes NSAIDs trigger it too. We want to reduce exposures to fumes and strong smells, try to reduce stress, believe the patients when they say they know their triggers. And I hate to say it because I want to say everyone can eat everything, but F, D, and C dyes in foods and medicines, red, yellow, blue, are a major trigger. One of my patients said when I diagnosed this, so this is why I can eat a bar of chocolate, but if I eat M&Ms, I get flushed. Then we go to medications. There's a lot of options, and you just have to titrate it with each patient. We want to start out with an H1 blocker twice daily to 4 times a day. It can cause some dry mouth or constipation, so just watch that. In the US, those are loratadine, fexofenadine, levocetirizine, and cetirizine, plus an H2 blocker. Again, let's block the histamine when it gets out of the mast cells, BID, plus a mast cell stabilizer. Why not start natural? Geroquercetin, I have no financial relationship, is the one that I recommend in the US, but there's a lot of different versions of quercetin that can be found on Amazon. And it's just an herbal that stabilizes mast cells. If that's not enough, we add other mast cell stabilizers, oral cromolyn, 10 milliliters 4 times a day before meals, going slowly, or compounded ketotifen, titrating up. For very severe cases, we may need a non-absorbed GI steroid after you've ruled out inflammatory bowel disease, or even omalizumab or Xolair injections monthly. Many mast cell patients end up on 5 or 6 medicines. This is very exciting because patients are not getting diagnosed. I mean, I've diagnosed a patient who was 69 years old. She had recovered her eating disorder many, many years before, but she heard me speak and she was like, I think I have this. At 69 years old, on treatment for this, she said she's never felt better in her life. I have another patient who's 29 that I just put on treatment, and she's one of my fastest responders. She feels like perfect. She didn't have a period. She had OCD. She had edema, pain, digestive issues. Gone. All of them gone. And her period came back month 1. But she looks back and realizes that when she hit adolescence, she had Isabella's story. Her eating disorder emerged from that. So we may be able to prevent avoidant restrictive food intake disorder and anorexia that comes from patients resisting food because it makes them sick. So lots of interesting things. Let's talk about the way forward. Health at Every Size, or HAES, advocates for accepting and respecting the natural diversity of body sizes and shapes, eating in a flexible manner that values pleasure and honors internal hunger cues, moving for joy and to become more physically vital according to ability and desire, advocating for respectful healthcare and supporting health policies that acknowledge the importance of social justice themes. It does not mean everybody in every body size is healthy. There are haters all over the world that every time I do something public about HAES, they question it and they think, oh, you just think everyone is healthy. Nope, that's not true. The founders of Health at Every Size in the 90s were wonderful pioneers. Probably in retrospect, it should have been called Worthy at Every Size, because everyone in every body size is a worthy person. Here's another one to Google. Put it in your phone, watch it, share it with patients. It's the best. It's the poodle science video from ASDA, the Association for Size, Diversity, and Health. It's such a cute little cartoon that shows dogs of different sizes and shows that not everyone can end up the same size. What does eating for joy mean? Well, food is not morality. All foods have a role. And the goal is abundant, unrestricted, satisfying food throughout the day with general balance and moderation. So here again, people say, Dr. G, are you saying people should just eat donuts all day? No, no, that's not what I'm saying. But I'm saying if you're in the mood for a donut, get a really good donut and eat it mindfully and enjoy it, no problem. What about moving for joy? Well, I just read an article cited here that was so exciting for me. Even though it uses words like obesity, which I don't use, it's a very exciting article, which shows that staying active and maintaining cardiorespiratory fitness is the most important determinant of health and mortality, independent of BMI. Check out that article. It has a wealth of data, among it that weight cycling, which is the standard outcome of dieting, it goes down, goes up more, down, up more. Weight cycling in the highest quintile of weight variation versus the lowest carried a 100% increased risk of negative cardiovascular outcome. So weight cycling is disastrous for health, and we have to avoid prescribing diets. So let's stop focusing on weight. We know that doesn't work, and instead promote self-confidence, awareness of social body pressures, and lifelong movement. So then what does weight-inclusive medical care mean? Because we're so involved in weight in medicine. Well, it's holding awareness that higher weight can contribute to the development of certain medical problems, as can trauma, stress, poverty, and otherization. And we still don't recommend weight loss or change of body as a treatment because it doesn't work and it harms people. There has to be a different way forward. This is my book. I checked. It is available on Mexican Amazon, and I'm delighted to say it has been accepted for translation into Spanish, so stay tuned for that. Gracias, and I am happy to take any questions.
Thank you so much, Jenny. It's always a pleasure to hear you. Muchas gracias. We only have 5 minutes, so I have one question here from the audience. Is how do you assess the low metabolism and improve it? Is there any medical treatment to be used?
Beautiful question. It is a narrative, not a numeric assessment. My prior job for 8 years was as medical director of the highest level of hospital medical care in the United States for patients with critical anorexia nervosa, BMI 10 kind of patients. And we did a number of studies using indirect calorimetry because what we observed was these patients were eating 500 or 600 calories a day when they arrived. And within 2 weeks, they were eating 3,200 calories a day, every bite monitored, every trip to the bathroom monitored, and they were barely gaining weight. And they were sweating, they had night sweats, they were burning calories. And we could not pick up this difference on indirect calorimetry. It's one of the last black boxes of macrophysiology, and we may learn that it has interesting things to do with the gut microbiome. But the answer is, if someone is restricting calories, they have a low metabolism, period. And if they begin to nourish consistently again, they will have a fast metabolism, period. Everyone's details will be different, but that's just how it goes. And there's no medicine. It's food. How lovely. The treatment is food.
Certainly. Okay, I have another 2 questions, so let's hurry. It says, how does genetic affects the treatment of obesity in the context of an eating disorder?
I've come to the point where I no longer accept the term obesity as a pathologic diagnosis for the state of somebody's body. That review study I just showed you described that in a big Veterans Administration test, the men who were considered to be obese and the most fit cost the medical system $10,000 to $30,000 less per year than the thin, unfit guys. So why are we labeling as a pathology a simple body size without assessing actual health? And the reality is that I say to every one of my patients who comes in, regardless of body size, I accept you. I accept that society wants you thinner. I accept that you might feel better thinner, medically, in terms of movement, in terms of self-confidence. But it's impossible to change your body size, according to all the studies, if we focus on your weight. Instead, we're going to focus on your mental health, on your relationship with food, and on your movement. And if your body size decreases, okay. If it stays neutral, okay. If it rises, okay. Because we cannot focus on weight as a primary outcome anymore.
Okay, so I think we still have time for one more. It's what questions should not be forgotten to be asked in the consultation so EDs are not overseen? And what is something that doctors usually forget to look on patients with eating disorders?
It's a beautiful question. Look, we are constrained by time in our practice. I'm so lucky in my practice because the people who come to me, I already know have eating disorders, and I have lots of time with them. But I think continuing to try to ask open-ended questions, it comes back to the whole thing that brought us into medicine in the first place, that relationship with the patient, that connection, that curiosity about the patient's story. So staying open and curious, you know, I noticed this, tell me about it. Even when I go to my kids' pediatrician, my daughters are 13 and 16, and they've got a great pediatrician, but she runs down the list. You don't have any eating problems, right? You don't have any sleeping problems, right? You don't have any school problems, right? And I mean, they don't, how lucky. But if they did, that would not be a very conducive environment to share. So if you notice weight really changing, ask questions in either direction. If you notice personality, temperament really changing, ask questions. Ask questions about their relationship with food, and you'll probably do a better job than almost anybody else they've ever seen.
Okay, Jenny, so unfortunately we're running out of time. You have a lot of congratulations on the chat, as you can see. Jenny understands Spanish, so she can read them. Gracias, Jenny. Un placer verte, un placer escucharte como siempre. Y te espero en Monterrey el próximo año, en junio, para el Congreso. Gracias a todos. Llenen la encuesta que está en el chat para la asistencia y el certificado, y los esperamos el próximo miércoles a la misma hora para hablar de neurobiología de los trastornos de la conducta alimentaria. Muchas gracias.
Gracias a todos.
Gracias, doctora Jennifer Gaudiani. Muchísimas gracias por haber estado con nosotros. Extraordinaria presentación, y agradecemos a toda la audiencia por su presencia. Y tal como dijo Eva, les recordamos responder a la encuesta de satisfacción. La liga está en el chat, y bueno, ese perrito nos da un toque de realidad. Muchísimas gracias a todos. Gracias, Jennifer, por haber estado con nosotros. Thank you very much.